Statistically speaking, you or maybe someone you know really well probably swallows a specific little pill every single morning.
Yeah, tens of millions of people take it.
Right. Levothyroxine, I mean, it's one of the most prescribed drugs in the world.
Absolutely.
But for a medication that we essentially hand out like candy, the way it actually works inside your cells is, well, it's kind of a biochemical mystery to most of the people taking it.
Oh, for sure.
So welcome to this deep dive. Today we're taking a stack of sources on thyroid replacement therapy, specifically treating hypothyroidism. And we're going to decode exactly what happens when you introduce this synthetic hormone into the human body.
It really is a fascinating master control system to explore because treating the thyroid, it isn't just about topping up a gas tank.
Right.
We're talking about this microscopic negotiation between molecular biology and, honestly, a patient's lived experience. And that negotiation is incredibly delicate.
Which, I think, brings us to the central tension of our dive today. Because for most of the 20th century, the medical definition of, fixing a thyroid basically meant the patient's fatigue lifted.
Yeah, their brain fog cleared up.
Exactly. But today, fixing it usually means hitting a very specific number on a lab test. So are those actually the same thing? We're going to find out.
Well, to understand why modern medicine is so heavily tethered to that lab number, we actually have to look backward.
Right, the history here is wild.
It is. We need to look at the really bizarre, truly groundbreaking way we first figured out how to replace this missing hormone in the first place.
Okay, let's unpack this because the year is 1891. We're in London, and a physician named George Redmayne Murray is looking at a patient with a condition called myxedema.
Right, which is severe, untreated adult hypothyroidism.
Yeah, and the patient has this puffy swelling in their face, limbs, a super slowed heart rate, and just profound lethargy. And if left untreated, the metabolism eventually slows to a halt, right?
Yeah, leading to coma and eventually death.
So Murray decides to do something completely unprecedented. He takes an extract of a sheep's thyroid gland, and he literally injects it into this woman.
Yep.
And she improves. She essentially gets her life back from this sheep extract.
And you have to keep in mind the timeline here, right? He was treating a disease caused by a hormone deficiency by simply replacing the missing substance.
Yeah.
14 years before the word hormone was even coined.
That is crazy to me.
I know. I mean, Ernest Starling didn't invent that term until 1905.
So they were completely flying blind.
Totally.
They had no idea what the active chemical ingredient was. They just knew the fluid from this sheep gland contained some kind of magic spark.
Right. And for decades after that, the standard treatment became oral desiccated thyroid extract.
Basically just ground up animal parts.
Exactly. They took animal thyroid glands, pig, sheep, cow dried them out, ground them into a powder, and put them in a pill.
But the problem with that approach becomes obvious when you think about the manufacturing process.
Yeah.
Because you're harvesting glands at a slaughterhouse.
Yeah, there's no standardization.
It's like imagining you're a baker, right? But you're forced to bake bread with a complete mystery amount of yeast every single morning.
That's a great analogy.
Sometimes the bread rises perfectly, sometimes it explodes out of the oven, sometimes it's a dense brick.
Right, because the potency from batch to batch of these animal glands was wildly unpredictable. It just depended on, how much hormone happened to be stored in that specific animal's gland on the day it died.
So you could take your pill on a Monday and get absolutely no relief.
Yeah.
And then take a pill from a new bottle on Tuesday and get intense heart palpitations.
Exactly. And that batch-to-batch unpredictability was a massive safety issue, which, is what drove the evolution toward precision.
So what changed?
Well, in 1914, Edward Calvin Kendall at the Mayo Clinic managed to isolate the active compound from thyroid tissue.
Okay.
He named it thyroxine. He actually later shared a Nobel Prize, though that was for cortisone. But the real shift happened in 1926.
Right, Charles Harrington and George Barger.
Yes, they mapped out the exact chemical structure of thyroxine and achieved the very first synthetic creation of it in a lab.
Meaning they no longer needed the slaughterhouse.
Precisely.
They had this synthesized molecule, the exact sodium salt of L-thyroxine. It solved this incredibly dangerous clinical problem of not knowing what was actually in the pill.
We moved from grinding up animal parts to delivering an exact pure molecule. And that molecule is what we now call levothyroxine.
Hold on, though. So we have this pure synthetic chemical. We give the patient the pill. But how does a single synthetic molecule actually replicate the infinitely complex energy demands of human metabolism?
It's a great question.
Because, I mean, the brain, the liver, the muscles,
Yeah.
they all need completely different amounts of energy at different times of the day.
Right. And to answer that, we have to look at the body's internal thermostat, the hypothalamic pituitary thyroid axis.
The HPT axis.
Right. So the hypothalamus in your brain releases a hormone called TRH that travels a tiny distance to your pituitary gland, telling it to release TSH, thyroid stimulating hormone. Okay. TSH then travels down into your bloodstream to your actual thyroid gland in your neck, commanding it to manufacture and release thyroid hormone.
And the thyroid mostly secretes a hormone called T4, right, along with just a tiny bit of T3.
Exactly. And those circulating hormones then feed back up to the brain to say, hey, we have enough hormone down here in the body, you can turn off the alarm.
But what's fascinating here is the math behind that feedback loop, right?
Okay.
Because the sources say the relationship between the hormone in your blood and the TSH from your brain isn't linear.
No, it's not.
It's log linear. Wait, let's
Yeah.
break that math down for someone without a calculus degree. What does that actually mean for the patient?
Right. So it means it acts like a highly amplified, hypersensitive hair trigger alarm system.
Okay.
A microscopic drop in your free T4 hormone levels doesn't just produce a small proportional rise in TSH. It multiplies the TSH response exponentially. Yeah, TSH operates on this incredibly tight normal reference range, typically around 0.4 to 4.0 MIUL. And because of that exponential math, the TSH spikes dramatically before the actual thyroid hormones even look depleted on a standard blood test.
So the brain's TSH alarm is basically screaming that the house is getting cold long before you can actually measure a drop in the room's temperature.
That is exactly it. And that extreme sensitivity is the entire basis for detecting what we call subclinical hypothyroidism.
Right.
Doctors look so closely at TSH because it reflects what the brain perceives the cellular reality to be, not just the absolute volume of hormone floating in the blood.
But, this introduces a massive paradox from our sources, and it honestly completely shifted how I view this drug.
Oh, yeah.
Yeah, because T4, which is what the synthetic drug levothyroxine is actually a prohormone.
Correct.
It has 4 iodine atoms attached to it.
Yeah.
But to actually be used for energy by the body, it needs to be T3, which only has 3 iodine atoms.
Right.
So T4 is basically 4 to 5 times less biologically potent. If T3 is the active hormone that actually gives cells energy, why on earth are we giving people a massive dose of T4?
I know.
It just sounds incredibly inefficient.
It does sound inefficient, until you realize it's actually a brilliant delegation of resources by the body.
How so?
Well, the healthy thyroid gland naturally secretes mostly T4 anyway. About 80 to 90% of its output is this inactive prohormone.
So it's like, okay, it's like giving a construction crew a massive truckload of raw lumber.
Right.
You aren't giving them the finished, livable house, which would be the T3. You're just dumping the raw materials on the lot and letting the body's individual tissues build the house on demand.
And that local control is exactly what saves us from systemic chaos.
Oh, interesting.
Yeah, the body handles the conversion of that raw lumber, the T4, into the active finished house, the T3, right at the cellular level. Tissues like the liver, the kidneys, the muscles, and the brain, they use highly specific enzymes called deiodinases.
Right, type 1 and type 2.
Exactly. D1 and D2 physically strip away one of those iodine atoms from the T4 molecule, activating it into T3 exactly when that specific cell needs energy.
And there's a braking system too, isn't there?
There is. Type 3 deiodinase, or D3. If a tissue has too much energy, D3 strips a different iodine atom off, creating reverse T3.
Which does what?
It's totally inactive. It basically blocks the cellular receptors.
Okay, so the brain might need a massive amount of active T3 to focus on a Tuesday morning, but the liver doesn't.
Right.
The body just uses the prohormone T4 circulating in the bloodstream and converts it locally.
Precisely. We're just providing the raw materials and trusting the body's internal enzymes to do the localized conversion.
Wow, so because the body is firmly in charge of this intricate tissue-by-tissue conversion process, taking levothyroxine requires a totally different mindset than most medications.
Oh, absolutely.
Like, you don't take it for fatigue and feel better an hour later like taking an aspirin for a headache.
Yeah.
You are forced to play a very long game.
You really are.
Let's look at the pharmacokinetics of that, like how the drug actually moves through the human body over time.
Sure.
A major misconception I hear from patients newly diagnosed is that missing a single dose is an absolute, call the doctor crisis.
Right. People panic.
But the sources highlight that levothyroxine is a massive molecule that clears the body incredibly slowly. It has a half-life of roughly 7 days in a healthy person.
And that 7-day half-life offers a massive buffer for daily adherence.
Really?
Yeah, I mean, if you forget your pill on Tuesday, taking two on Wednesday isn't going to cause a physiological earthquake. The body's circulating pool of T4 barely registers a single missed day.
Oh, wow. But the flip side of that massive buffer is, well, the agony of waiting.
Yes.
If a patient is sitting at home, completely exhausted, and the doctor increases their dose, it takes 4 to 6 weeks for that new dose to reach a steady state in the blood.
It's a long wait.
Being told to wait another month when you feel like garbage is agonizing.
It is incredibly frustrating for the patient, but biologically, the endocrinologist's hands are tied here.
Because of the half-life.
Exactly. They prescribe a new dose and say, I'll see you in 6 weeks, because they literally cannot recheck your TSH any sooner. The log linear mirror hasn't settled yet. Treating to a lab number is just an inherently slow, iterative process of trial and error.
Speaking of the precision required for those numbers, why do doctors and pharmacists treat generic switching with this specific drug like you're handling uranium?
Oh, the generic debate.
Yeah, like if I get generic ibuprofen from 3 different pharmacies, nobody cares. But with levothyroxine, they warn you never to switch manufacturers.
Well, it comes down to the mechanism of how pills are physically constructed and absorbed. The FDA classifies levothyroxine as having a narrow therapeutic index.
Okay, what does that mean?
For most drugs, a generic just has to deliver between 80 and 125% of the active ingredient into your blood compared to the brand name.
Wait, that's a huge window.
It is. But because of that hypersensitive TSH alarm system we talked about, if your thyroid medication swings by 15%, your TSH goes crazy.
Oh, right.
So back in 2004, endocrine societies petitioned the FDA, and the FDA tightened the rules specifically for levothyroxine. Generics now have to hit a much tighter window, around 95 to 105%.
But even with tighter rules, the actual ingredients in the pill still cause problems, don't they?
They do.
Explain why a generic from company A acts differently in my body than a generic from company B if the active hormone is exactly the same.
It's all about the inactive binders and fillers.
Like what?
Things like lactose, starch, talc, or specific dyes. These fillers dictate exactly how fast the pill dissolves when it hits your stomach acid. So if Company A's pill dissolves very quickly, but Company B's uses a denser filler that dissolves slowly, the medication hits your small intestine, which is where it actually gets absorbed into the blood at completely different rates.
So you could be absorbing 80% of the hormone from one brand and only 60% from another, which completely crashes that delicate log linear feedback loop. You take the exact same microgram dose, but your body receives less hormone.
And this absorption issue actually extends to your morning routine, too.
Oh, right. The breakfast rules.
Yeah. The physical chemistry of levothyroxine makes it highly prone to binding with other substances in the gut. If you take it with coffee or a calcium supplement or an iron pill,
What happens?
those substances chemically bind to the levothyroxine molecule in your digestive tract, creating a compound that is just too large to pass through the intestinal wall. It just gets excreted.
So taking your pill with a morning latte means you're basically flushing a chunk of your medication down the drain.
You really are. You have to take it on a completely empty stomach with water and wait an hour before eating or drinking anything else.
It demands an incredible amount of respect.
It does.
So, assuming a patient respects the empty stomach rule, how does a doctor decide the initial dose?
Well, the standard full replacement dose is roughly weight-based. It's about 1.6 micrograms per kilogram.
Okay, so a 150-pound adult might need roughly 100 to 112 micrograms a day.
Around there, yeah.
But the sources highlight a strict medical mantra: start low, go slow.
Yes, very important.
Especially for older adults or anyone with a history of heart issues, they might start on a tiny dose, like 25 micrograms. Why not just give them the full dose they need on day one?
Because thyroid hormone essentially sets the idle speed of your entire basal metabolic rate.
Okay.
When you increase thyroid hormone, you increase the body's baseline demand for oxygen. The heart has to pump faster and harder to deliver that oxygen.
Right.
So if you have an older patient or someone with hidden coronary artery disease, their arteries might be narrowed by plaque.
Ah, I see. So if you suddenly slam their system with a full replacement dose, the heart muscle screams for oxygen to keep up with this newly heightened metabolic rate.
Exactly.
But the clogged arteries can't deliver it.
And that oxygen starvation is what precipitates angina severe, crushing chest pain, or even dangerous electrical arrhythmias. The start low, go slow principle is a direct mechanical respect for the profound cardiovascular burden this hormone can place on a fragile system.
So we have precise synthetic molecules. We have exact mathematical lab targets. We understand the gut absorption mechanics. It sounds like a perfectly solved, beautifully engineered medical equation.
It does sound like that.
But for a massive demographic of patients, this entire framework completely fails.
Yeah, this is arguably the most fiercely debated area in endocrinology today.
Right. What happens to the 10 to 15% of treated patients who have a perfectly normal TSH lab result, yet their symptoms never leave?
It's a real problem.
The doctor points to the paper and says, "Great news, your numbers are perfect, you're cured." But the patient is sitting there with crushing brain fog, persistent fatigue, and low mood. They know they aren't cured.
So the debate centers around the pro-hormone concept we discussed earlier.
Okay.
Does giving T4 alone monotherapy shortchange some patients? We know a healthy human thyroid gland secretes both T4 and a small but vital amount of direct T3.
But standard levothyroxine provides zero direct T3.
Correct. So patient advocacy groups and some doctors argue we should add synthetic T3, a drug called levothyroxine, to mimic natural biology.
Makes sense to me.
But the clinical frustration is that when we run large randomized controlled trials comparing T4 alone versus T4 and T3 combination therapy, the broad population data generally fails to show consistent, reproducible benefits in quality of life.
But wait, the data says one thing, but thousands of vocal patients swear by the combination therapy. Are they just experiencing a placebo effect?
Well, not necessarily. The answer likely lies in genetics. Yeah, research points to a genetic polymorphism, a structural variation in that type 2 deiodinase enzyme, the DIO2 gene.
Ah, the localized enzyme that acts as the carpenter, turning the raw lumber T4 into the active T3 house.
Exactly. If your specific genetic blueprint builds localized enzymes that are simply less efficient at making that conversion, then T4 monotherapy is going to leave your peripheral tissues starving for energy.
So your central brain thermostat, the TSH, might look perfectly fine on paper.
Right, because the pituitary gland relies on a different mechanism to sense hormone levels. But your muscle and brain cells are trapped in a state of localized hypothyroidism.
That perfectly explains why some patients absolutely thrive on combination therapy, getting that direct T3 hit, while the clinical trials, which just average everyone out, show no overall benefit.
Yes. But currently, medical guidelines reserve combination therapy mostly for patients who remain highly symptomatic on optimized T4, rather than using it as a first-line treatment.
And this ongoing frustration is driving a massive resurgence of things like Armour thyroid and NP thyroid, isn't it?
Oh, absolutely.
Which are just modern branded versions of the desiccated animal thyroid extract from a century ago. Patients are actively demanding it because it feels more natural and inherently contains both T4 and T3.
But mainstream guidelines push back hard against animal extract for two distinct biological reasons.
Which are?
Well, first, the batch consistency issues we discussed from the 1950s still linger today. But more importantly, the evolutionary biology is mismatched.
Explain that mismatch. Why does it matter if the hormone comes from a pig?
Because a pig has different metabolic and evolutionary demands than a human.
Fair.
A pig's thyroid gland naturally produces a T4 to T3 ratio of about 4:1, but a human's physiologic secretion is closer to 14:1.
Wait, so if a human takes a pig's thyroid extract, they're getting a massive relative flood of active T3.
You are bypassing the body's carefully regulated, localized conversion system entirely.
Oh.
Flooding the human bloodstream with that much ready-made T3 frequently causes heart palpitations, anxiety, and sleep disturbances. It is natural for a pig, but it is deeply unnatural for human biochemistry.
That reckless flood of hormone really highlights how potent this master switch is.
Yes.
But that extreme potency is exactly why we have to be so incredibly careful with vulnerable populations, especially when we look at the extremes of this medication.
The stakes literally couldn't be higher.
Let's talk about those extremes.
Well, on the extreme end of having too little hormone, you see myxedema coma. This is the life-threatening total decompensation of untreated hypothyroidism.
Right.
The body loses its ability to maintain temperature. The cardiovascular system begins to collapse. Even with modern medicine, mortality is between 25 and 50%.
And because the gut physically stops absorbing nutrients in that state, you can't even just give them levothyroxine pills, can you?
No, they have to administer intravenous hormones just to restart the body's engine.
It's a stark reminder that this drug isn't a vitamin supplement. It's a fundamental, non-negotiable requirement for human life.
Exactly.
But on the other end of the spectrum, we see this incredibly dangerous trend. People without any thyroid deficiency intentionally misusing this medication to lose weight.
Yeah.
The sources called it thyrotoxicosis. Basically fake or self-induced thyrotoxicosis. What mechanically happens to the body when you do that?
You're basically pressing the fast-forward button on your body's cellular machinery and all the gears start stripping. When a healthy person takes exogenous thyroid hormone, they aren't generating healthy energy. They're suppressing their own natural production and creating a state of iatrogenic or medically induced hyperthyroidism.
You're just forcing the system to consume itself.
Yeah. You risk crippling anxiety, rapid bone density loss because the bone turnover rate accelerates, and a very real risk of atrial fibrillation, a chaotic, irregular heartbeat that can lead to stroke.
That's terrifying.
And any metabolic weight loss benefit vanishes the moment you stop taking it, but you might be left with permanent structural damage to your heart or your skeleton.
It's treating a master metabolic control system like a casual diet pill. It's crazy. Let's look at one more scenario where getting the dose exactly right is critical: pregnancy.
Yes, this is where levothyroxine shines as one of the greatest triumphs in preventive medicine.
Okay, tell me about that.
When a woman with hypothyroidism becomes pregnant, her dose of levothyroxine typically needs to be increased by 30 to 50% almost immediately upon confirmation of the pregnancy.
Wait, you just said start low, go slow. For adults to protect the heart against sudden metabolic demands.
I did.
So why throw the rule book completely out the window and increase a pregnant woman's dose by 50% immediately?
Because the physiological adaptations of pregnancy demand it. And more importantly, there is a second life relying entirely on that supply.
Right.
In the first trimester, the fetus has literally zero functioning thyroid tissue of its own. It relies 100% on the maternal thyroid hormone crossing the placenta.
And what does the fetus use that hormone for?
Neurodevelopment.
Oh, wow.
Without adequate maternal thyroxine crossing the placenta, the fetal brain cannot form proper neural connections. The cognitive development is severely and permanently compromised.
So the urgency is real.
Exactly. The mother's cardiovascular system is already adapting to support the pregnancy, so the rapid dose increase is absolutely necessary to protect the fetal brain.
And that vigilance extends right to the moment of birth, too. Every newborn baby in the U.S. gets a heel prick blood test, checking for congenital hypothyroidism.
Right. Babies born without a working thyroid gland.
And historically, before this simple test, those babies would suffer from irreversible, profound intellectual disability, right? A condition historically termed cretinism.
But today, we detect the missing hormone on day one. We introduce this incredibly cheap, synthetic pro-hormone pill within the first couple of weeks of life, and it completely prevents the brain damage.
That is amazing.
The child grows up with entirely normal cognitive function. As cause and effect stories go in medicine, it doesn't get more miraculous than replacing a single molecule to save a human mind.
When you look at this entire journey, from George Redmayne Murray injecting sheep extract in 1891, to understanding the elegant mechanics of the pro-hormone converting locally in our tissues, to the agonizing 7-day half-life wait for a blood test to normalize, it all points back to the profound complexity of treating the human body.
It really does.
We've replaced the mystery yeast with precise generic molecules, but the negotiation between the lab number and the patient's lived experience is still an ongoing dialogue.
Which brings us back to that original tension, treating the patient versus treating the number.
Right.
And there's a final layer to this debate that is crucial to think about, particularly regarding the elderly.
Okay, what's that?
We know from large population data that as human beings age, our natural TSH norms begin to drift upward. The body's metabolic thermostat seems to naturally turn itself down a few degrees as we enter our 70s and 80s.
Which logically makes sense. I mean, an 85-year-old body doesn't have and shouldn't have the exact same baseline metabolic energy demands as a 20-year-old body.
Exactly. So here is a thought to mull over. If our bodies naturally and purposefully shift their metabolic thermostat down as we age, maybe modern medicine's aggressive obsession with fixing older adults by forcing their TSH back down to match a 20-year-old's lab parameters is completely backward.
Interesting.
What if, in our relentless quest for perfect standardized biochemical numbers, we aren't curing a disease at all? What if we're actually just fighting a natural, highly protective adaptation of the aging human body?
Wow. It makes you wonder, when we stare at that lab report, are we reading an objective blueprint of health? Or are we just looking at a snapshot of a moving target we still don't fully understand?
It's a great question.
Thanks for joining us on this deep dive. We'll catch you next time.